Welcome back to another Oncology for the Inquisitive Mind special ASCO update. Today we will be talking about lung abstracts. I'm Joe, that's Frank Hardy, and we're the Hardy Boys. I'm kidding, I'm Josh and it's Mike. Mike, how are you tonight?
I'm good, Josh. I'm not sure how many of our listeners will know the Hardy Boys, but that's just displaying our age, how old we are at heart.
I'm pretty sure it was old when we read them.
True, very true.
Mike, do you want to get right into it tonight and talk about NeoTorch? But before we do, I think I just need a flag. We will talk about Adora coming up in one of our later episodes, but at the moment we've got so many things to cover, we wanted to leave that till last, and we'll talk about some other exciting updates.
Adora is so big that I think it needs sort of its own segment. So, yeah, we will have a special plenary episode to wrap up this series. Let's get on to today's episode, which is looking at lung cancer, specifically early lung cancer. There will be a metastatic lung cancer episode later, so you might notice a bit of a theme in some of these abstracts. The first study to talk about is NeoTorch, which is Perioperative Toripalimab plus chemotherapy in resectable stage 2 to 3 non-small cell lung cancer. There is a emerging body of evidence, and I suspect that very soon this will become a standard of care, where a combination of chemotherapy plus anti-PD-L1 or anti-PD-1 antibodies in the neoadjuvant plus minus the adjuvant setting for patients with resectable non-small cell lung cancer is efficacious, and I'm sure that this will become a standard of care very soon. Studies that have explored this include Checkmate 816, Aegean, and the Keynote 671 trial, which incidentally was also presented at ASCO and published in the New England Journal of Medicine, one of those simultaneous publish and present, which I always find really, really cool. However, we've talked about pembrolizumab, we've talked about it to death, so figured we would give toripalimab its moment in the sun, because NeoTorch does have a couple of other quirks to it, shall we say. Interim results from NeoTorch have been presented at a previous ASCO plenary session. To summarise, it is an anti-PD-1 agent that has demonstrated significant event-free survival improvement over neoadjuvant chemotherapy alone. In the study, there were 404 patients who had resectable stage 2 to 3 non-small cell lung cancer. They had to be free of all mutations because, as we'll see in our Adora episode, that's kind of blowing everything else out of the water. So EGFR and ALK wild type, although interestingly, they didn't mention some of the rarer mutations such as ROS1 or MET, and they had to have measurable disease. Patients were randomized 1-to-1 to receive toripalimab or placebo in combination with chemotherapy. Cycles were every 3 weeks, and patients received 3 cycles prior to surgery, which was compared to 4 cycles in the Aegean trial, and 1 cycle after surgery. So the amount of chemotherapy patients are getting after surgery when they're probably at the highest risk of things like wound complications, neutropenic sepsis, that sort of thing, is actually relatively small, which is good. After completion of the chemotherapy plus IO component, toripalimab or placebo was given up to 13 cycles every 3 weeks. Primary endpoints were the event-free survival in the stage 3 cohort. In the overall cohort, interestingly, and it's a point potentially against the study that they didn't look at just the phase 2 patients. And the secondary endpoints were overall survival, the pathological complete response rate, which again, there's potentially still a little bit of debate as to whether PCR in cancers not named breast actually correlates with outcomes, disease-free survival, safety, and feasibility of surgery. We'll jump right to the TLDR, shall we say, the important stuff, the results, because the demographics were relatively similar across both sides. Although I will say that the majority of patients, and this is interesting for a non-small cell study, were squamous histology. Majority of these sorts of studies will have adenocarcinoma as the most common histology because that's how it is in real life. But this is specifically a squamous heavy study, which might actually impact how toripalimab is used in the real world. Very few patients did not receive surgery, so 17.8 versus 26.7% in both groups. So it's a good hit rate of cancers not progressing. We know that lung cancer is obviously fairly quickly progressive disease. And the R0 resection rate was incredibly high, interestingly, in both cohorts, 95 versus 92%. So there is a slight benefit there. The event-free survival had a hazard ratio of 0.4 and the 20-month EFS rate of 64.7 versus 38.7 months. So we've talked in previous episodes about how the recurrence rate of lung cancer is absolutely abysmal, but the addition of toripalimab in NeoTorch is definitely adding a benefit. Interestingly, there was a benefit pretty much across all PDL1 expression rates. So even in patients who had less than 1% PDL1 expression on TPS, the hazard ratio was 0.59. The degree of response still broadly correlated with the amount of PDL1 you express. So the more PDL1 you express, the better your response. Again, and this is another interesting point, the benefit appeared to be better in patients who had squamous histology versus non-squamous. So the hazard ratio was 0.35 in squamous cell patients versus 0.54. And interestingly, the non-squamous hazard ratio was not clinically significant with a p-value of 0.08. So we know that toripalimab works really well in squamous cell patients, ideally with a high PDL1, but less appears to work less well in patients with non-squamous histopathologies. Complete response rate, or the major pathological response rate at surgery, does appear to be predictive at outcomes. In patients in the toripalimab arm who had a major pathological response, the hazard ratio was 0.24. And interestingly, the hazard ratio in the placebo arm who had a major pathological response was 0.22. In terms of PCR, the hazard ratio in the toripalimab arm was 0.16. And interestingly, the rate of PCR in the placebo arm did appear to be lower than in other studies with a similar setup. So, not really sure how to explain that one. The overall survival data is immature, and the fact that we can just say that about a lung cancer study is great. The hazard ratio, the in progress hazard ratio, we might say, is 0.62, and there's a clear delineation of the curves. So, in conclusion, toripalimab plus chemotherapy significantly improved event-free survival. We don't know about overall survival yet, but early signs are good. Major pathological or complete pathological response did appear to correlate with a better event-free survival, and there is some correlation between PD-L1 expression and benefit, but it's good across all levels. The major takeaway that I had from this study was the discrepancy between squamous and non-squamous histopathology. Squamous, I don't know about you, Josh, but in my experience, squamous has generally been the nastier of the two histopathologies. Obviously, there's significant heterogeneity, but when I see a metastatic squam, I think, oh, they're probably not going to do as well. So the fact that we've got something to use in patients with early squamous cell cancer is really, really good. The other caveat, I guess, is that we don't really test for things like EGFR and ALK in squamous cell cancers because there's not evidence of efficacy or significant incidence there.
I have one quick question with this study. Why is it that the hazard ratio for major pathological response was somewhat better in the placebo arm than the toripalimab arm?
That is a very good question and not one I can really answer, to be honest.
Because my understanding is chemotherapy is significantly ineffective with lung cancer. Maybe squamous, it's more effective, but that's just an interesting sidebar if you look at that. And then if you look at PCR for toripalimab was 0.16 and there was lower rates in the placebo arm, it's just an interesting side point.
Yeah, I suspect that the definition of MPR might have significant heterogeneity as well. If you have an MPR, yes, you do better overall. Whether the addition of toripalimab actually improves that remains to be seen. I guess it'll all sort of shake out. But the big takeaway with this study is that it is yet another piece in the emerging puzzle where the picture is showing a definite benefit of if you catch a lung cancer early, give them chemo, give them immunotherapy. At this point, in places like America where you can access pretty much anything you want, you're spoiled for choice. You can have Pembro, you can have Nivo, you can have toripalimab, but give them a combination, and they will do better.
Wise words as always. Michael, I'll jump to our next
Please do.
abstract and presentation, which was NeoPredict.
Which is different to NeoTorch.
No, yes, that's it. So this is neoadjuvant nivolumab, which we all know, plus or minus relatlimab. So background, we know CTLA4 and PD-L1 is established in treating cancers, but we need novel therapies because of resistance and ineffectiveness. What this is looking at is that a randomized phase 2 study comparing neoadjuvant nivolumab plus relatlimab, which is a LAG3 inhibitor, versus nivolumab alone, followed by surgery and standard of care therapy.
I'll give you a quick peek behind the curtain there, listeners, in case he edits it out, but Josh took 3 goes to say Relatlimab there.
Thanks, Mikey. The rationale, multiple ligands, it's supposed to help with other aspects of immunogenicity and it's independent of PD-L1. The primary endpoint for this was surgery feasibility within 43 days and multiple secondary endpoints. The standard ones, disease-free survival, overall survival, R0 resection rate, and safety. Patients enrolled were the classic stage 1 to stage 3A resectability, and there was 30 in each cohort. Most common was adenocarcinoma and a couple of squamouses sprinkled just for fun. Common stages was 1B and 2B. Results, the important part. 100% of patients achieved surgery within 43 days. Muzzle tov, that's amazing. 57 of 60 or 98.3% had an R0 resection and similar surgical complication rates between the arms. There were low rates of treatment-related adverse events and complete pathological response was 13.3 versus 16.7. Favored relatlimab, the LAG3 inhibitor, and major pathological response also favored relatlimab, 27 versus 30%. So outcome was as follows. At the 12 months, disease-free survival was 91%, which is pretty amazing. And 12 months overall survival was 96%. This is a small study. There was a high proportion of really early stage cancers that would normally not receive adjuvant neoadjuvant therapy. But this may be driving the benefit, but maybe practice is changing to include these guys in the neoadjuvant sphere. We're uncertain of the benefit given LAG3 over nivolumab alone, and more time will be needed to really look at these results and see if there's any long-term efficacy. The positive aspects of this trial is that neoadjuvant immunotherapy, again, may be effective without chemotherapy and may expand indications of preoperative therapy beyond stage 2 and stage 3A. Would have been good to see a control arm without treatment, although this is likely very unethical.
Yeah, I don't think that given the mountain of evidence that neoadjuvant treatment works and works really well, you could really convince an ethics board or, more importantly, patients to not get treatment or that there will be a risk of getting placebo. An interesting point with this study as well, Josh, is the dose of the Nevo that they gave was 240 milligrams. And for those who aren't familiar, that's half of the standard dose that is normally given for patients with, say, melanoma. Common consensus is that immunotherapy has a much lesser dose effect relationship or dose response relationship than chemo because it's working in a very circuitous way. But it would be interesting, I guess, to see if we're not going to have a control cohort with no treatment, to see if nivolumab 480 milligrams had a better outcomes. And the flip side of that coin is more toxicity.
Toxicity versus benefit versus overall survival. All very challenging questions that ASCO very much tried to address.
Yeah, but it will be interesting to see, particularly with this sort of study, if immunotherapy is really coming for chemo's lunch money and is trying to sort of muscle it out of the neoadjuvant lung space altogether. I wonder if that's where we'll end up.
Well, based on the evidence and the data, I think that might be, but I'm not a betting man. Michael, let's talk about our final trial.
Yeah, so this is an earlier stage study because we do like to sprinkle those in here on Oncology for the Inquisitive Mind. It's not all big phase 3s. We've got to give some lip service to the little guys as well. So this is a study that is looking at a novel biomarker in small cell lung cancer. Now, this is notable for a couple of reasons. Number one, small cell lung cancer is notoriously difficult to recruit to trials because It is so rapidly progressive, even by lung cancer standards. Josh, the average prognosis for an untreated extensive stage lung cancer patient is
You're rolling the dice how many weeks you're going to live.
a lot. Given that a lot of studies mandate, say, for example, a 4-week washout period, so you can't be on systemic therapy for a number of weeks to make sure you don't have any residual benefit from your previous treatment. That is the difference between a patient sort of trundling along and staying alive to being very, very close to death in small cells. So it's very difficult for there to be any significant research in this area. So, new targets are desperately needed. And the target that this study was looking at was DLL3. Now, DLL3 is a surface cell marker that is frequently expressed in small cell lung cancer, but only infrequently expressed in other solid tumors and normal tissue. So it's quite small cell or high grade sort of neuroendocrine tumor specific. DLL3 directs T cells. Sorry. The drug under study was the very catchily named BI764532. I'm sure they'll come up with something much more marketable down the track. But it's a novel DLL3-targeting T cell engager with activity against CD3 and anti-DLL3. So it directs T cells to lyse DLL3 expressing cancer cells. So hopefully there's a lot more specificity and targeted nature of this drug. The drug, which I'm just going to call BI from now on, demonstrated potent preclinical anti-tumor activity in DLL3 positive cells in xenograft models. But this is a first in human dose escalation trial, so this is ground zero. This is where it starts. In patients with small cell lung cancers or neuroendocrine carcinomas. I'll focus on the small cells because they comprise the majority of the population. So the inclusion criteria, you had to have a high-grade neuroendocrine type tumor, you had to be DLL3 positive, and you had to be ineligible for standard therapies and yet still have a good ECOG performance status. And yet somehow they managed to scrounge up over 100 patients, 107 to be precise. The majority had had 1 to 2 prior lines of therapy, including immunotherapy, almost certainly atezolizumab, and a slight majority had either brain or liver mets at 56%. So, because it's a small phase 1 study, the focus is dose finding and safety. So, the treatment related adverse events took center stage, unlike many of the other studies, and treatment related cytokine release syndrome was present in 59% of patients. Now, Josh, I don't know if you've seen cytokine release syndrome when it gets bad, but it can be really, really scary.
I've seen it a couple of times, mostly in patients treated with tebentafusp and uveal melanoma, but nothing apart from that. It's very much a hematological specialty.
Well, I think it's something that's weaseling its way into the oncological space because I've got a couple of phase 1 trials that have fairly high rates of CRS, but it can be very, very scary, and it can cause significant mortality and morbidity. Fortunately, with the BI drug, the majority of cases of CRS were only mild, grade 1 to 2, and none required significant immunosuppression with things like tocilizumab. The rate of decreased lymphocyte count, that was the other major toxicity, was 4%, and the rate of dysgeusia, or a general feeling of unwellness, was 20%. These side effects were well tolerated. In terms of response, specifically looking at small cell lung cancer, so 26% of patients had a partial response, 26% of patients had stable disease, and 30% of patients had progressive disease. So, promising response in a notoriously very hard to treat cancer, knowing that these patients have probably already gone through carbo, ETOP, and atezo, and probably something like CAV or single agent paclitaxel. So they've had something beyond what we would call standard of care. There is an ongoing response in 14 out of 18 patients who initially had a response, who initially had a partial response. So there is the potential for, if you're one of these about 25% of patients who responds initially, for you to have a sustained response. And in small cell, that's great because the rate of recurrence is very, very high. The median duration of response has not been reached. So in conclusion, this is a very exciting study, and there is a chance that it may peter out as it progresses to phase 2 and hopefully phase 3, but we hope that this is probably the first targeted therapy specifically for small cell lung cancer. So we're in that wonderful state of pupation where that's the word, isn't it?
Sure, let's go with it.
Yeah, let's go with pupation. Where the possibilities are endless. This could be the next immunotherapy, but it also has a long way to go. So the most important things from this phase 1 study is the safety is clinically acceptable and manageable, very low rate of discontinuation at 4% with promising efficacy. So we have ongoing dose optimization. We're still finding what the most effective dose is, but it's something that will hopefully revolutionize the treatment of small cell.
Michael, it would be wonderful if DLL3 or something like an equivalent could be like the next generation of immunotherapy, because we've got immunotherapy now. We know it works. Not all immunotherapies are equal, but next generation looking at different targets that's not PD-1. We already know PD and PD-L1, while it's good for looking at response, it doesn't always correlate, and we need better markers and we need better ability to tell our patients, is this treatment going to work? This is why. This is what our next line is. We need to be hematology now, or what we want it to be now, so we can sort of say we can cure you, or at least give you long-term control.
That's the holy grail, and I think that is a goal that will be constantly working towards. I mean, people much smarter than us will be continuing to turn up new cellular markers and coming up with ways to try and attack them, and hopefully we'll get there.
And we'll continue to report it. But stay tuned for our next ASCO episode. Mikey, what are we doing now?
Next, we will be looking at the lower intestinal tract with a look at colorectal and specifically rectal cancer. So we'll see you tomorrow.
See you there.
Thank you for listening to Oncology for the Inquisitive Mind. You'll find previous episodes on our website, along with weekly posts, resources, and links to our Twitter and LinkedIn pages. Check it out at inquisitiveonc.com. That's inquisitiveonc.com.